So Dr. Kabbani is an assistant professor in the Division of Infectious Disease at the University of Alberta. Her clinical focus is infection in the immunocompromised host. She is the education lead for the Transplant Infectious Disease Fellowship Program at the University of Alberta. Her research area included epidemiology and outcomes of infections, organ transplant recipient, and more recently, response to COVID-19 vaccine and organ transplant. So welcome, Dima. It's a real pleasure to have you here. Just as housekeeping, if you have questions, don't hesitate to type them in the chat, and at the end there's going to be a Q&A session, and I'll be moderating that session. So don't hesitate to ask your question in using the chat below. So Dima.
Thank you, Melanie, and good afternoon, everyone. Let me share my slides. Okay, so what I'll try to discuss in the coming 30 or 40 minutes, the third dose COVID-19 vaccine in our solid organ transplant recipients. So these are my disclosures. Before we discuss vaccination and our solid organ transplantation, I think it's important to know what's happening currently in Canada with the COVID-19 pandemic. As you can see on the graph on the left, that we're in our fourth wave in Canada, but what you can appreciate, although the numbers are increasing, the numbers for mortality, which is the lower graph on the right, are not increasing exponentially as we have seen with the first and second wave. And this can be explained mainly by the vaccinations that are luckily working well against COVID-19. So if we look at the distribution of confirmed cases reported to PHAG by vaccination status as of September 4, we can see that the majority of the cases are in unvaccinated. Again, hospitalization and death are mainly in the unvaccinated population. But we still see some hospitalization and death in our fully vaccinated patients. And if we look at how many has received at least 1 or 2 doses of COVID-19 vaccine, so there is 75% of the total Canadian population that has received at least 1 dose, and 69, and this is early in September, so the numbers have increased since then. So but if you look at different provinces, the uptake of vaccination has not been equal. And so you can see, for example, in Alberta and Saskatchewan, it's only in 60 to 62% as compared to other provinces that are as high as 73%. Okay, so now I can't move my slides anymore. Okay.
I think someone is doing a switch for you.
Okay, it's working again. Okay, so what are the approved COVID-19 vaccines in Canada? So we have the mRNA vaccine, so the Moderna and the Pfizer-BioNTech. And then we have the adenovirus vector vaccine, which is the AstraZeneca and Janssen. And as you can see, there's some new brand name. I'm sure you've heard about them that are even hard to pronounce. And I'm not sure a lot of us are going to be using them, but we'll stick to the names we already know. So some of the names, for example, for Moderna, it's now called Spikevax. And then for the Pfizer-BioNTech, it's called Comirnaty, just in case you see these new nomenclatures. What is still good in the general population, and it's reassuring that even against different variant like the Delta variant of SARS-CoV-2, the vaccine are still protective against severe disease and symptomatic infections. So when we look how good or endpoint of vaccine efficacy, we look at different stages. So first we look how well are they preventing infection, then how well are they preventing actually symptomatic disease, hospitalization, preventing ICU admission and death, but also preventing transmission to others. And the thing is, it's not. There are different variables that play into role that goes from exposure, infection, and some patient characteristics that are related to poor outcome. So for example, if we look at the likelihood of exposure, someone, for example, that works in a healthcare setting has a higher risk of exposure than somebody that does not. But these patients usually have more protective equipment to prevent exposure. And our transplant population, most of them have multiple risk factors in addition to the immune suppression that makes them at a higher risk of poor outcome. And so the way these vaccines work, so they're given intramuscular, and then the body forms an IgA, IgG, so antibody response, and a T cell response that works at different stages. So even at the beginning, at the infection stage, then once we're infected at the replication stage to decrease viral load and then symptoms, and that helps decrease transmission. So what do we know about COVID-19 outcomes in our solid organ transplantation? So this is a large retrospective cohort of solid organ transplantation. And that was done early in the pandemic, so before vaccination. And at that time, the mortality among solid organ transplant recipients that were hospitalized with COVID-19 in the US was up to 20.5%. So again, this is early in the pandemic. There's no good data of patients that were non-hospitalized. And in this cohort, the drivers of mortality were increased age above 65, congestive heart failure, chronic lung disease, and obesity. If we look at our Canadian data, so this is a cohort from the University Health Network from March 2021 to 2021. They included 161 solid organ transplant that were infected with SARS-CoV-2. 4.3% were asymptomatic. 60% required hospitalization, and from these, 43% required supplemental oxygen, and increased age and having 2 or more comorbidities were associated with the need of supplemental oxygen requirement, and 22.7 required mechanical ventilation, and 15.6% died. The numbers are close here in Alberta. Early in the pandemic, again, from those that we know that got SARS-CoV-2 that were symptomatic, our death rate was around 17%. So what do we know about mortality compared to non-solid organ transplant? So there have been several matched cohort, and I'm just showing one from New York by Pereira et al., where they match solid organ transplant to non-solid organ transplant that were hospitalized with COVID-19. And what's impressive is that they didn't really see any mortality difference at 28 days follow-up. However, there's certain things that would keep in mind is that most of the patients included were not early post-transplant. We know there wasn't long transplantation where the mortality has been described up to 40% in certain cohort. And although there was no increased mortality, there was increased morbidity, so more ICU admission and need for hospitalization. So let's move on to vaccines. But before we talk about COVID-19 vaccines, let's go over some of the principles of vaccines in our solid organ transplant recipient. So the most important thing is in our solid organ transplant is that prevention is key, because we know from other viruses such as influenza that it can cause severe disease in our solid organ transplant, and it's associated with increased mortality. What we also know from other vaccines is that the solid organ transplant recipient are less likely to mount an immune response after vaccination. And this is why we like, when we can, to vaccinate patients pre-transplant, or when we can, to wait at least 3 to 6 months after they've been transplanted. However, that's not always possible in an outbreak setting, such as influenza, so we would vaccinate as early as 1 month. And different strategies have been studies to try to increase this immune response of vaccines in the solid organ transplantation. So for example, in influenza, there's a clinical trial that showed that high dose vaccine is actually more immunogenic than standard dose vaccine. And then some other studies that looked at the boosting, so extra dose in influenza. And what was reassuring with other vaccine is that vaccination are not associated with rejection. So let's move on to the COVID-19 vaccines. And the way I see it is, first, I want to make sure that they're safe in our solid organ transplantation recipient. Then I want to look at the immunogenicity data of these vaccines, and then what we have from efficacy and effectiveness. So let's start with safety first. And if we look at the data from multiple of these observational studies that have been published this year, looking at the safety after first and second dose vaccine, there was no reported cases of acute rejection. There have been no reported cases of neurological diagnosis. So for example, Guillain-Barré, Bell's palsy, or neuropathy. There were no cases of allergic reactions to vaccines. What we saw, and what's also seen in general population, is our local site reaction. So for example, mild pain at the site of the injection, which ranges from 25 to up to 61%, depending on the study. Mild redness reported in 7% of these patients, and mild swelling at the site of infection. Were also reports of systemic reaction, so fever, chills, fatigue can range up to 38% after first and second dose vaccine, headaches, and myalgia. In this cohort of solid organ transplant recipient from Toronto, what they described is that they did not really have any cases of rejection, and they tried to grade the severity of illness into mild, moderate, and then if it affected the daily activity, and grade 3 and 4 would be more moderate and severe. And so if you look after the local events, they were mainly grade 1 and grade 2, and more common grade 2 after your second dose, and it was mainly pain as the main local events. If we look at the systematic events on the right side, then it was around 50% with the first dose, and it was increased a bit to 60%. And they only described one grade 3 event, which was a varicella zoster virus reactivation, and one patient that required hospitalization and a lung transplant that developed fever and shortness of breath after their first and second dose. So this is about safety of dose 1 and 2. So what about how well these vaccines protect us? So when we look at the immune system, I like to think about it as an antibody response, as a cellular response. So several studies now, authors have reported the humoral response after COVID-19 vaccines. So in general, these vaccines have a lower response compared to immune competent, also a lower response compared to SARS-CoV-2 infected solid organ transplant. The problem is the different studies that use different assays, so it's really hard to compare, but I'll just give you some numbers to show you how low humoral response to vaccine was seen after first and second dose. So after first dose, up to 15% only had a humoral response, and after second dose, for example, in a cohort of lung transplant, 0% had any humoral response, and it ranges from 0 up to 54. And again, these are different assays that were used. If we look at the same study by the Pali Kumar that looked at Moderna in 127 solid organ transplant, and it compared it to a COVID-19 infected patient. So this is the anti-RBD level, which is the anti-receptor binding domain level. And if you can see, the median level increased after their second dose. But if you compare it to those that has been infected, it's still much lower. And they also looked at the percentage neutralization. Again, there is increase after your second dose. So what are some of the factors that were associated with reduced likelihood for generating humoral response in the study? So the use of anti-metabolite, shorter time from transplantation, patients with lower EGFR, so worsening kidney function. In a recent study in a heart transplant cohort looked at found that a higher CRP was associated with a reduced likelihood of generating a humoral response. So what do we know about the cellular T-cell immune response after a second dose? So not a lot of groups have looked at this. I mean, it's more expensive than doing antibody response, and it requires more work. But what we know so far is that again, the T-cell immune response is lower compared to controls. Again, lower cellular response in vaccinated solid organ transplant compared to those that are infected with SARS-CoV-2. But what was reassuring is that cellular responses were evident even in the absence of measurable antibodies. So even when we were getting these early data about low antibody response, we were still encouraging our solid organ transplant recipient to go ahead and get vaccination due to the cellular response. And this because we know that assessing only a humoral response may underestimate the immunogenicity of these vaccines. So going back at the same study that I've mentioned earlier, so they looked at specific CD4 Tcell and CD8 Tcell responses. And after the first dose, only 10% had a CD4 Tcell response. After the second dose, it increased to up to 50%. And what's also was shown in the study is that several patients with a negative anti-RBD response still had a positive CD4 T-cell response. Up to 50% of these that did not have an RBD response. So moving on to the real world experience after 2 doses of vaccine to see if they work. So this is a UK registry linkage analysis. And what they clearly show is that the case fatality ratio for death within 28 days of onset in vaccinated patients after 2 doses was dropped to 7.7 from 12.6 in those that are unvaccinated. So these vaccines work in solid organ transplant. This is another study that looked at clinical effectiveness of COVID-19 vaccination in solid organ transplant recipient by Dima et al. And again, it showed a decreased incidence rate in those that are vaccinated. So they just reported 61 cases in unvaccinated and 4 cases in vaccinated, and 2 out of the 61 died from the unvaccinated and 0 over 4 in the vaccinated. And on the right, you can see the Kaplan-Meier curve that demonstrate a significant difference in the cumulative probability of developing COVID-19 in those that are vaccinated compared to those that are not. This is data from Spain after 2 doses, and each circle represents an infected case, and the colors represent SARS-CoV-2 serology. And as you can see, the numbers of cases in the upper graph decreased from the time pre-vaccination to after vaccination. And if you look at the lower graph, again, the numbers that died in the pre-vaccination time compared to the post 2 doses of vaccination, they did not have any death. But I mean, we need to take into account what was the circulating variant at that point. We need to take into account what the country was doing was there more restriction or less restriction? So it's all we only need to look at all these factors when we analyze these. Despite saying all of that, we and others have described their experience with the breakthrough COVID-19 infection after 2 doses. So Miami has described the 26 cases of breakthrough vaccine. What's interesting is that the main exposure in these is when you have an unvaccinated family member. So this is why it's very important that the family members are vaccinated to protect these patients. But the outcome of these breakthrough infections, so 50% were hospitalized, 46% remained as an outpatient and received monoclonal antibody, and death was 7.6%. So their breakthrough rate was 0.87% for infection, which is much higher than in the general population. And then a multi-center US study from 17 different centers with available data, again, described a 9.3% death and a breakthrough rate of 0.83 for infection and 0.077 death. And so this is, again, much higher than the general population. I think, I mean, something to think about is we don't always get an appropriate numbers, because sometimes there might be certain solid organ transplantation transplant recipients that are infected but don't get tested, or for example are infected but remained asymptomatic. So what about 3rd dose vaccine and solid organ transplant? So what do we know so far? So again, I'm going to talk about safety in immunogenicity, and unfortunately, we don't really have any efficacy data so far after the 3rd dosing. But if we look at the safety after 3rd dose, again, pain at injection is common and a bit higher than we saw with the 2nd dose, and the pain at the site of infection was more described in younger solid organ transplant infection, again, systematic symptoms. There was no allergy reaction, again, no neurological complication, and no rejection in most of these study. There was one heart transplant that developed a biopsy proven antibody mediated rejection 7 days after 3rd dose, but their heart function remained normal. So what do we know about the humoral response after this third dose? So again, a third dose showed that there is an increased antibody response compared to a second dose. So for example, in a kidney transplant cohort, 49% of those that did not develop an antibody response after their second dose did develop an antibody response after their third dose. In studies that describe neutralizing capacity, there was an increase. But again, even despite 3 doses, a large proportion of our solid organ transplant remain at risk for COVID-19. What about cellular immune response after third dose? The inducible T cell response was up to 80% in a heart cohort. And again, the cellular responses were evident in the absence of measurable antibodies, suggesting the cellular benefit. So we can't talk about third dose without mentioning the randomized trial of a third dose of mRNA vaccine. This was the Moderna vaccine in 120 solid organ transplant recipient at UHN. The third dose or the placebo, so they were randomized, 60 received a third dose of Moderna and 60 received a placebo. These were given 8 weeks after the second dose of vaccine. The median age was 66.6, and the median time from transplantation was 3.16 years. Again, let's look at the safety. So they did not report any grade 3 or 4 side effects, and there was no rejection. If we look at the local adverse event, you can clearly see that pain was much higher in those that received the Moderna vaccines compared to placebo, and there was more erythema. If we look at systemic adverse event, again, there were more fever, chills, and fatigue, both grade 1 and grade 2 in the Moderna arm compared to the placebo. So what about humoral and T cell response? So if we look at the first graph, A, which is the anti-RBD antibody response, you can look at the median with the Moderna vaccine is much higher than the placebo, and this was statistically significant. You see an increase in the anti-RBD antibody in the Moderna arm and some in the placebo arm, also encouraging the neutralization percentage much higher with the Moderna vaccine compared to the placebo. And if we look at SARS-CoV-2 specific CD4 T cells, again, higher with the Moderna vaccine compared to the placebo. So we get asked a lot about this and patients really as a feeling of security would like to know what the serology shows before or after a third dose vaccine. And the simple answer is no. And the main reason is that we don't really have a threshold currently that predicts protection. And then even after 2 doses and some after 3 doses, solid organ transplant will still have an antibody level which is below the one achieved by healthy control. And then when we measure antibody, we're not measuring T cell responses, and we know that these T cell responses increases after the second and third dose, despite those that even have a very low or no antibody response. So There's still a lot of remaining question. So when is the timing? When is the best timing for a second and a third dose vaccine? As you know, in Canada, certain provinces. For the timing between the first and second dose, that was delayed beyond the 28 days, 21 to 28 days recommended by the manufacturer. So is this delay even in solid organ transplant? Does it materialize in more humoral response or T cell response? We don't know. We hope we could answer this in our PREVENT study, which is a multinational study that's currently conducted, headed by Dr. Kumar, with collaboration of CDTRP. If we have enough patients that received this delayed vaccine. What about mixing vaccine? So giving a vaccine that has a different type of vaccine, would that give us a more robust immune response? What are breakthrough infections after third doses? And what should we do about these non-responders that despite 3 doses of vaccine, they don't really respond? Should we give them more vaccines? Or should we give them other type of prevention? And then unknown if the protection will persist after transplant or revaccination will be necessary. So this was still a question, but a recent study, very small, in kidney transplant, compared those that actually were vaccinated pre-transplantation, and these had and maintained a superior humoral response to SARS-CoV-2 vaccine compared to those that were given post-transplant. So I still think we should continue to encourage those that are being evaluated or listed to be vaccinated, and hopefully more and more data will convince them. We know that from other vaccines, so we don't expect it to be any difference with the COVID vaccines. What else can we do other than vaccine? So I think this is for all our solid organ transplantation and for those that might not have a response. So this is in vaccination, what we call the cocoon or community of immunity around them. So if you look at this group of people, the red ones are the ones unvaccinated and the blue ones are those that are vaccinated. And we have here, for example, one transplant patient that have a low response rather than being unvaccinated. So if we have unvaccinated, then it's going to be the virus is going to be transmitted and it's going to reach, for example, the child that's unvaccinated and the transplant that might have a lower response. However, in this group of patients where most of all the people surrounding these transplant or kids are vaccinated, then the virus cannot really reach that patient. So what we're encouraging all our solid organ transplantation is that to get vaccinated with 3 doses, make sure friends and family and caregivers are vaccinated, encouraging outdoor activities, continue to wear a mask when indoor and public spaces, avoid crowded indoor venues, always hand hygiene, and if they get infected or exposed, to contact the transplant programs, because now we have some monoclonal antibodies that are available that we could use in these patients if they present early. And then we should advocate that all healthcare workers working with transplant patients be vaccinated to protect the solid organ transplant recipient. So saying that, our advice in Alberta has been more firm lately. As you know, we are leading the country in the number of cases, and because there is so much circulating virus, it is we're seeing more of our vaccinated solid organ transplant patient get infected and even develop severe disease. So I've been on service the last week, and unfortunately, we've had 2 or 3 every day despite vaccination. And we even have one patient that developed moderate to severe disease after 3 vaccination. So I think the advice should be a little bit more firm. So again, vaccinate, ensure family members are vaccinating, but we're encouraging not to have any indoor dining or visits, and then to avoid any large events, because we've had some of our organ transplant be infected either from their family members who are not vaccinated, or in, for example, wedding or other big events. To try to do delivery pickup rather than going into an indoor shopping area, masking, and then regular hand sanitizing. So in conclusion, what do we know after 3rd dose? Most of the data is with mRNA vaccine. So 3rd dose mRNA vaccine is that it increases SARS-CoV-2 specific humoral and cellular responses. It has an acceptable safety profile, but some of our solid organ transplant recipient will continue to have poor immune response and potentially remain unprotected. We need more data assessing long-term vaccine effectiveness, and then the impact on the rate of rejection is required, so more data. And then the best timing, I think, for 3rd doses is unclear, but the majority are encouraging their solid organ transplant to get vaccinated 2 months after their 2nd dose. And so with that, I'll stop and take any questions.
First of all, Dima, thank you so much for this amazing presentation. I think you covered it really well and explained it very well. I see that we're starting to have questions in the chat. Don't forget that you can ask your question and write your question in French, or, well, in English, of course, or in French or Spanish, and we can translate, no problem. Okay. So Victoria is asking, since morbidity and mortality is higher, generally in those with comorbidities, should we be also advising as healthy lifestyle as possible to reduce the impact of comorbidities?
Of course, I mean, some of the comorbidity that can be modified with lifestyle should be encouraged. Some of these comorbidities are already existent. For example, chronic lung disease, kidney disease that unfortunately we can't do much at this point, and it makes our solid organ transplant more vulnerable to this disease.
So I think, so there might be, I hope Victoria answers your question. If you have other questions, please don't hesitate to put them in the chat. She said, thank you. So I think you answered her question. One question that I have, what do we know about pediatric
So the data is trickling in pediatric. I know part of the PREVENT study, we're going to have a solid organ transplant group, but what we know so far is that safety is not a problem. We were worried about seeing more side effects with possible pericarditis, myocarditis that we have not seen, and then the immunogenicity data that we have is actually very good.
Excellent. And I think data is coming out right now for even vaccination and younger children, right?
Correct, and the non-transplant, yeah.
One more question that I have. Sandra is saying, if everyone as an indoor event is fully vaccinated, is a mask required?
So I think it all depends on what's happening where you live. In general, we are saying if everybody's vaccinated, to try to limit the numbers of people, like if it's two families, then vaccines are not required. But what we're seeing in Alberta with the high circulating virus, we are encouraging all our solid organ transplant to wear masks indoor.
Thank you. So Sean is commenting, although some of us who know Dr. Montgomery know he's a bit of a cowboy in spite of being a transplant surgeon. What are the thoughts on the controlled temporary weaning of one or more immunosuppression drug to increase the effectiveness of a vaccine in SOT? Good question, Sean.
So I don't think we're there yet. I mean, we worry with reducing our immunosuppression that we're going to see more rejection. So I don't think we should be encouraging our solid organ transplant to decrease their immunosuppression, so they would have more response.
Excellent. Another question for solid organ transplant recipient is fully vaccinated. Is fully vaccinated 2 or 3 doses?
So I mean, the terminology for booster, which is an extra dose, applies for non-transplant. I think for fully vaccinated solid organ transplant, it should be 3 vaccine. With that said, the data that I showed when I mentioned fully vaccinated is with 2 vaccines, not 3 vaccines, because it was done prior to the 3rd dose vaccine.
Excellent. Jeff is asking, thank you for the talk. What is your opinion on requiring COVID vaccination pre-transplant to be listed? And if so, 2 or 3 doses vaccine?
I mean, I mean, I know that a lot of centers are looking into considering pre-transplant vaccination a must, and I believe the data is coming, and we know that immunogenicity of vaccines, if given pre-transplant, is much better if it's giving a post-transplant, and we know that the morbidity and mortality of solid organ transplantation with SARS-CoV-2 infection, especially in the early period, is high. So I know some centers have moved on to mandating pre-transplant vaccination for COVID-19 vaccines, but it's not the case everywhere.
Yeah, absolutely. Any news on the booster 4th dose for SOT recipients?
There's been just some one study, I think, that looked at, and it showed increase in antibody. But I mean, the problem is, I don't think, that's my personal thought, is that I don't know that continuing to give vaccine is going to be the answer. So what about 4th dose? What about 5th dose? Because most of these studies are just measuring antibody response, and we know with the way I presented that antibody response is not the only response that we get with vaccine, and then there's the T cell response, which we don't measure when we just check an antibody response. Some patients, I believe, that despite 3rd dose, 4th dose, 5th dose vaccine, they might still be at risk. And I'm talking about some of our lung transplant recipient, for example. And in these patients, we need to think about other modality to either one, increase immunogenicity rather than continuing to give boosters, or considering other prophylactic strategy.
Thanks, Dima. So Nilima, I'm sorry, I jumped over your question, and I see that Daniel also has almost the same question. already got third dose vaccine. How do we know if we have enough antibody developed? Is there a test to verify levels or protection?
Yeah, and this is a question that we get a lot, and we encourage a patient not to get an antibody test first. Not all antibody tests that are available measure antibody response to vaccine, which is the anti-spike. And some of these antibody responses just measure the fact if you've been exposed or infected with SARS-CoV-2, so that is a problem. The other thing is even in those that don't have an antibody response, we have the T cell response that we're not measuring with these antibody response. And the third thing is we don't really know what these numbers mean and at what level these numbers are protective. So against the advice is don't do these antibody tests. We know that the vaccines will protect solid organ transplant patients compared to non-vaccinators, and have shown that there's been a decrease in mortality, but breakthrough infection will still happen, and that's why I would continue to follow some of these protective measures like distancing, masking, hand hygiene, and all of that.
Thanks a lot. So Manuel, actually from our team, great presentation, Dima. You mentioned that there are early intervention options for the SOT recipient. Can you expand on this? Is this an option available across Canada?
And so it's not an, I mean, it's an intervention in say, and it's available in Canada. So we're using more monoclonal antibodies now that we have them in those that are infected and are early. The big question, and I don't know that anybody has looked at this, is whether in non-responders, whether these monoclonal antibodies could be given at a certain interval to try to prevent them from getting infected. Most of these monoclonals available in Canada are through IV, so I don't know that we're getting there, but these are things that I think we need to look more into going forward.
Is that what you were referring to in terms of prophylactic earlier? That maybe in the future.
Yeah.
Recipients. Yeah.
Yeah.
Okay. So from Christian, again from our team, does the type of organ that has been transplanted impact the risk of a severe COVID infection?
Yeah, absolutely. That's a great question. I mean, we've seen much more severe disease in our lung transplant patients as compared to non-transplant patients.
And I think in the Prevent COVID study, we're actually recruiting a different organ type and different immunosuppression regimen, right? So to address some of these questions, interesting question. Okay, I don't see any more question. Please don't hesitate. We still have a little bit of time with Dima, and this is absolutely great conversation. I have an additional question maybe in terms of variant. So what do we know about variant, the importance, so Delta versus South Africans and so on?
I don't know about specific data in solid organ transplant, but we know that the Delta is much more transmissible in general compared to the Delta and other variants, and can be associated with increased disease. I don't know that we have enough in our solid organ transplant population to comment on that, but I would expect it would behave the same way.
And do you believe it's going to be like you hear in the press and so on. And I'm just thinking about the crowd here. Is it going to become something we have to live with, and like the influenza? And
I would think so. Eventually, when that's going to happen, I don't know. I think there's a lot of things, more variants, vaccination locally and worldwide, and other factors that will play into role.
And in terms of Canada, the impact of the temperature or the winter summer cycle on these infections.
I don't know if it's gonna be related to a certain season. I know that, I mean, what we're seeing is from the activities that changes from an indoor to an outdoor, more transmission when we're inside, but I don't know that if it's going to be a seasonal or not.
Sean is asking, without some type of antibody testing confirmation as marker of protection, how can an SOT recipient who travels for work or pleasure have a sense of when those activity might be able to safely resume for them? What marker or measure should be watching as an overall group?
So it all depends on where that person is traveling, and I would, without the antibody numbers, I would still follow the precaution measures that I would follow in travel and then outside travel. I don't know that the antibody test should be what makes us feel protected or unprotected, because again, I don't know what the number means, and there are other types of immunity. So it's I think it all also depends on where we're going, what's happening with variants, and then more than than just an antibody level.
Yeah, Sandra is asking almost the same question. What is the future test to determine protection? It's not clear right now, right? Because even in healthy people, we don't know what the level of antibodies is associated with protection. Correct. Right?
Correct.
So I think we still need to understand a little bit more what is important in that protection. Christy, how confident can recipient be that is safe around fully vaccinated family and friends when breakthrough infection are a possibility, especially if masks are not worn? Yeah.
So that's a good question, and I mean, we know that the non-immunocompromised vaccinated, hopefully when they're vaccinated, then they're less likely to become symptomatic and even transmit SARS-CoV-2. So if your own bubble, and I'm not saying Thanksgiving dinner where you have extended family sitting in a small cohort, especially now with what's happening in Alberta. But if you have your cocoon that is vaccinated, I think the transplant recipient will have much more protection, even without masking at home on a daily basis.
Mm-hmm. Yeah, I think it refers to the fear of asymptomatic vaccinated person, giving the transmitting, but as you say, the cocoon might be the right strategy. So Crystal is asking, will the recorded session be made available? Of course, on CDTRP website, and you have the link in the chat. So yes, you can listen to Dima's excellent presentation and this conversation again for sure, and share it with the people that might be interested. Any more question? I see, I think we covered it. So you ask now if you have another question. If not, I will really thank Dima for this amazing presentation and answering all these absolutely essential questions. I think we can say that we're going to come back with more data as they come, right? And we'll make sure that the community get informed as soon as possible as the data is available. I think it's important for patient, donor, and family, but as well as our, transplant community as a whole, including health care workers. So Dima, thanks again.